Professor Toutouzas, thank you very much. Professor Guagliumi, thank you very much. I would like, from my point of view, to thank Grigoris for this fantastic invitation. It's a great honor for me and a great pleasure to be here for the second time in a row. And I think this meeting is highlighting how the pathway on how we should perform contemporary PCI. So I'm going to kick off drug-eluting PCI. So this is a case of a 40-year-old male, a young gentleman, with symptoms shortness of breath on moderate exertion, some chest discomfort as well, on exertion, but also at rest. He has a background of recently diagnosed dyslipidemia, arterial hypertension, for which he started some medication, nebivolol 2.5 milligrams OD, valsartan 160 milligrams on OD. He's a heavy smoker, about 25 years, 20 cigarettes per day, but also has a strong family history of ischemic heart disease. His father had a heart attack at the age of 48. In terms of echocardiogram, nothing significant. Some diastolic dysfunction and LVH due to the hypertension, and his ECG was normal as well. Regarding his bloods, he has dyslipidemia and slightly increased NT-proBNP, especially for his age, and the echocardiogram, and a normal renal function. So what next? I mean, in principle, what I do in this kind of cases, I proceed with a CT coronary angiogram. And this is the CTCA of this gentleman. So now I'm going to focus on the target vessel, which is the LAD. And now we can appreciate here we have a long diffuse disease. We can appreciate there's a mixed soft plaque, but also calcified plaque. We can see that we have lesions in the bifurcations. There's two diagonal branches, large diagonal branches. And also we can appreciate that there are also some high-risk features, soft plaque with positive remodeling of the vessel. So we can easily get some very nice information in the first instance about who we're going to deal this vessel when we proceed with the next step, which will be a coronary angiography. So this is the left system. I can tell you from now, this is a left dominant system. You can see there's a huge left circumflex, an extremely short left main, and we can appreciate angiographically that there's some, I would say, ambiguous disease in the mid-LAD. So we can see there are two sides, one after the first septal branch, and then at the bifurcation with the diagonal branch, there's around 60%. So what will be the next step in order to decide what to do with this case?
Any comment from the discussant? So you have these patients, younger patients.
Yes, thank you very much for being here. Okay, we have a new patient, 42 years old, and we have a lesion in the mid-LAD that appears diffuse, like atherosclerosis in all the LAD branch. But in the mid-LAD, this plaque needs to be investigated. We have to make some imaging or an FFR to be sure what to do next, because always we have to think that he's 42 years old, and he can make a lot of things, like stop smoking, like take statins or something like this.
So let's comment a little bit about the difference between, you said, I had the CCTA and you saw, and now you are seeing in angio. Many things are similar. Something seems to be a little bit different. Likewise, very diffuse seems to be less diffuse here in angio compared to what we saw. Do you want to comment, please?
Yes. Well, of course, we all know coronary angiography is a two-lumen. It's a luminography, so we don't get to have the three-dimensional images that we have with the CT. But there is not a lot of calcium, so it's in the coronary in the CT, so it's pretty accurate. So most of the times we believe what we see in this setting in a young patient, 42 years old. So definitely this is a case that we shouldn't place a stent without further investigating. So to place a stent in the mid-LAD without further imaging or FFR, it doesn't make sense. It's a bit interesting that there seems to be the flow at the distal part of the LAD is zero. So it looks like there's no, it's occluded at the end of the vessel. So this is something that we take into account as well.
Perfect, especially in RAO. You can see that the apical portion of the LAD is not fully filled.
Yes, definitely.
Yeah, but I think the catheter is not, it's placed directly
That
to the...
is the other point.
So
the left main is a little bit narrow, and we have two vessels and not one to put the
Okay, very
catheter.
short. The catheter is oriented toward the circle, so we needed to be very cautious in judging.
Fantastic. So
would
that's
like to
why
make a
on the
comment
second
on-
picture there's a guiding catheter and a wire just to be able and visualize the LAD in a full range.
this,
So the
comment
other
on
one is
your,
a diagnostic.
On your question regarding the discordance between CT and angio, I fully agree with you because there was an eccentric spot, calcified spot on CT, right, at this point. And this makes more difficult, I think, the sensitivity to, or the accuracy of CT to have an accurate measurements in this spot. So we see it, and okay, so what's the next step?
Okay, so the next step, physiology. So that was my preference. And we did a resting index, so a resting full cycle ratio. We can see that is negative. And then as a protocol, we proceed to microcirculation and FFR assessment. And now we can appreciate that actually the FFR is positive, it's a 0.78 in a symptomatic patient. And some borderline, normal microvascular function with an IMR of 24. So if you consider 25 as the abnormal value. So next step.
Andreas did for microvascular function, and we see quite normal CFR. So CFR is 3.5. There's a discrepancy between CFR and FFR. There was a study that looked on that and didn't show any added value. But we have to point that out, that there are a lot of times that our measurements don't necessarily agree. If someone was a believer of CFR, I don't know, like Peek in Amsterdam would say that the physiological study is negative for significant stenosis in the epicardial vessel. Just a comment.
So what to do?
I will go with FFR.
Okay, we are going with the FFR. Is positive.
Just make this point because
Or-
of physiology.
Super.
And I have to
Okay.
We need more
physiology.
information.
He did the physiology, he did the full physiology. Now we have some discrepancy based upon FFR and then decision.
Well, I have to say, if I make a comment, a brief comment, so this is very surprising for such a short lesion to do an FFR of 0.78. But we have to believe what we see, I suppose. Yes.
It was not so short. Let's go to the imaging and see.
Definitely is not short, as we can see from the CTCA. Secondly, 30% of angiographic lesions, we have a discrepancy between the physiology and what we see anatomically on the angiogram. So that's why we do all these tests. So,
On the other hand, just to make another comment on FFR, we use FFR as a binary tool, but it's not a real binary tool. So if you have above 80 or below 80, when you are close to this threshold, it's not mandated to do one or the other. You have to use also your clinical judgment. You have to take into account other things like the patient profile, and maybe in this case, imaging and the quality of the plaque.
So I completely agree. I was not sure either, especially with this discrepancy. Young patient, what we're going to do now? Put stents, what we're going to do? So next step, intravascular imaging. And now we have the capacity to use this new cutting-edge technology, which is a dual modality catheter utilizing the intravascular ultrasound and the near-infrared spectroscopy. And the special feature with this catheter, so I'm going to run the pullback, is that we can detect lipid. So, and I find this as a very useful information on how we're going to stratify the plaque risk, plaque vulnerability, how we're going to define our strategy on when we're going to treat this lesion, and then to optimize our PCI. So we can appreciate here that actually we have pretty tight lesions. So in both two diagonal branches, we have mixed fibrous plaque, we have calcific plaque, and then now we can appreciate even before the diagonal, so as the pullback is running, we can see that there's a fibrous, huge burden plaque. I'm going to show you next the measurements. And again, small luminal area. I'm going to let the IVUS run. We can see the yellow part of the arc. That means that this plaque is filled with a lipid. Here is some calcium. And here is the actual minimum luminal area. It's the second diagonal. We can see it's 2.9 square millimeters. We have a plaque burden, which is mild to moderate, 53%. And we also have a high lipid core burden index of 484.
Can you stop for a second?
Yes.
Because I'm not sure that everybody catch immediately the sense. Number one, you have a cross-section and you have longitudinal view. Can you see clearly? And in the longitudinal view, you have the proximal part now is on the left side and the distal part is on the right side.
Correct.
So the yellow spot, there are two major yellow spots. One spot is more or less at the level of this distal lesion, mid-distal, but the other ones is at the level of the ostium of the LAD. And that is going to be important in a patient of 43 years with LDL of 140. That is going to be a very important message why we needed to get the full pullback and why we needed to write the report. Because it's not only the segment we are treating, but also to pass the information to the world that perhaps we needed to be extremely aggressive in terms of anti-lipidemic drugs in this case. Please, sorry.
I completely agree with that. So the high density is actually in the proximal segment of the LAD. As you can see, the yellow square segment at the top, sorry, I'm going to show that here. So this LCBI max of 484 corresponds to this area. Okay? So here on the next slide, we can actually characterize the different segments. So this is the distal reference vessel. So we can appreciate it's a 3 millimeter vessel. Here it's a diagonal branch. We have a fibrocalcific lesion with a minimum luminal area. And then we have actually on the other bifurcation, the more proximal diagonal, again, we have a fibrocalcific lesion with a minimum luminal area of 3, which actually is not appeared angiographically, as we can appreciate here. And then in the more proximal segment, just after the septal branch, we can see there's a huge fibrous plaque with plaque burden 78% and a minimum luminal area of 3.3. I'm sorry I haven't shown you the ostium LAD, but I can tell you the minimum luminal area is around 7.5. So,
so based upon the lumen, nothing to be done proximally, but
exactly.
to be taken into care for the future.
High aggressive.
Yeah, but we have to agree that it's a very diffuse disease right now. I mean, it's not like a sport lesion that we considered from angio from the beginning.
Correct. And we have some identity about the plaque burden from where to where, the size of the distal reference. So any comment from the discussant?
So now I'm convinced that it's a diffuse disease. We see some negative remodeling at the location of the second diagonal branch, and probably positive remodeling at the proximal part of the vessel. So, yeah, it needs to be treated. So
Absolutely true. Absolutely true. Where there is the bigger plaque burden is going to be positive remodel, while at the level of the bifurcation, the lumen and the vessel seems to be smaller compared to the distal reference. So very, very pointed comments about also the negative remodeling.
Which is very interesting for a young patient of 42 to have these regional differences in the remodeling. So, yeah.
So essentially, we have the challenges of a long lesion, we have a young patient, and we have some vessel size discrepancies. So we need to choose now which is the most appropriate strategy to treat this case. So we're going to put metal stents, we're going to do drug-eluting balloons, we're going to use bioabsorbable scaffolds. Difficult. So anyway, so we proceed with the drug-eluting balloon angioplasty. So the first thing is we need to, based on the imaging, decide how we're going to modify the lesions. So essentially, because we have a mixed feature plaque, so we have some lipids and also lipided plaque, but also quite lots of fibrous plaque. I'm a bit quite aggressive. And essentially, what we did is that we used cutting balloons, we used scoring balloons. So for the distal vessel, I'm going to show you now here. So we used an angioscalt, scoring balloons, a non-compliant balloon, 2.5 millimeters. So we went 0.5 millimeters below the actual reference diameter, and we went up to high pressures around 16, 18 atmospheres. So that's the burst pressure for this balloon. Then we use a Scoreflex 3.0 in the mid-segment here. The actual vessel diameter was 3.5. And then for the more proximal lesion, which was quite fibrotic, we use a cutting Wolverine 3.5 millimeters. Again, I'm going to high pressures there as well, 16, 18 atmospheres, even though it's a compliant, semi-compliant balloon. So that's
let's be aligned. So fibrotic means elastic recoil. And so he decided to make incision, and a significant incision at the most segment involved by fibrotic tissue with a cutting balloon that is making more deep incision compared to the scoring balloon that is a little bit more superficial. So this is based upon imaging. Plaque interpretation, he was mentioning calcium, but the calcium was marginally present, and you have also reverberation. In IVUS, when you have a very thick calcium, you are totally shadowed below the lumen surface. When you have some thinner calcium, you can still see the signal behind. And that is telling you that you can be less aggressive toward the calcium. There was the reason why he decided in this way, correct?
Correct. And I think we should aim, we need to disrupt a lot the vessel structure in order to achieve a better outcome, and aiming for a bit of medial dissection, of course, on the same time, respect the flow and all the other issues. So our next step was to check. So check what we did. So we used the intravascular imaging again. And here's the run of IVUS. So on the right side, we can appreciate some still images, and we can see the luminal areas is massively improved. On the bottom picture is the first diagonal branch lesion. You can see now we achieve around 7 millimeter square minimal luminal area. We can appreciate the actual medial dissections here.
So medial dissection means hematoma.
And we'll see in a bit.
Here you can see the incision at the 4 o'clock.
4 o'clock
here.
And then before there was a black contour going around. So the lumen was
and again here.
Clearly improved. But then we will discuss about the hematoma. And then back again.
So based on these images, we're quite happy to proceed with a drug-eluting balloon. So we use a sirolimus drug-eluting balloon, a 3.0 and then 3.5. And here is the final angiographic result. I think it's quite good. We don't have any flow-limiting issues.
But
here.
you can see there is some staining.
Yeah.
That is in line with the hematoma. You can see at the end of the injection. That is important. So the way we are checking is how much we gain in terms of lumen. We try to get media dissection, but hematoma is a different animals. And then we needed to take into consideration when we are judging about the results. Question.
Thank you very much. Andreas, a great talk and a great example. All these exams getting together to give you the knowledge and the power to decide the best for the patient. I was excited, and when I heard about your final option or your treatment, I was a little bit skeptical, and I'm going to ask you this. I don't know if this we gain the lumen. Lipid is still there, right? I don't know. We did a DCB. Yes, there is medication there. There's limus there for some 6 months, a year. I don't know. But what about the pathophysiology of the plaque? We know that maybe it's an unstable plaque there. I want to ask you if it's a hybrid approach in this situation. I know that it's a young patient, but if it's a hybrid approach to a stent, the last part of the vessel, which was more, to say, more stenotic or more lipid, and do a hybrid approach with a DCB upwards. That was my thoughts. Okay, I don't know if you agree or you can comment.
So question is that according to your vision, you must perform also physiology at this point?
No, excuse me, I will explain. According to my vision, I don't know if a DCB, or we have data for that, a DCB will solve the problem of the lipid, of the unstable plaque, the problem of we gain lumen, we have the medication there, but it's a young patient. Do you seal the plaque? Yes, do you seal the plaque? Mechanical. So if it's an alternative to do a stent to the worse segment with a lot of lipid, which was the last part of the vessel, and to do a hybrid approach with a DCB upwards.
But anyway, you need to forgetting the results. When you have the maximum plaque burden and this is fibrotic, you need to make incision and a dissection into the media. There is a huge paper written by the Japanese in 300 cases showing that one of the predictors of a target vessel failure with a DCB is if you don't have incision of the media. But here, the incision were more compared to what normally we wanted to have because you have an hematoma. So we don't know because there were so few data collected by using imaging and physiology in guiding DCB. So until this point, as I said, in the consensus, TIMI3 flow, and you have a TIMI3 flow. Residual stenosis lesser than 30%, and this is the case, and no dissection type F, leave it. That is good for DCB. But in fact, we are seeing there are a lot of information based upon physiology and imaging that we can gain when we are using DCB, especially in a younger patient.
Congrats, Andreas. Great case. I would be most worried about the plaque that had the fibrotic for the recoiling, not the mid one, though.
The proximal part.
Yeah, the proximal part for using the DCBs, but it's an excellent result. I wouldn't be worried about the hematoma, and I would leave it like that. But
okay,
one question:
how
many minutes do you wait till you insect?
How many minutes you wait?
After the DCB, you inject. Do you wait?
No, I inject immediately. If you're asking me how many minutes I leave the DCB dilated, inflated, it's about 2. I aim for a long inflation.
Okay.
So, I mean, that depends, of course, on how the patient feels, because if there's lots of pain, I have to stop. But I'm aiming for longer inflations, especially with DCB. But I'm doing the same for the lesion modification as well. So, like the old-fashioned, plain old balloon angioplasty. But anyway, just to give you some more information, the first one is I had a huge debate about the patient just in case that we had to put stents, because this is a procedure that's a bit unpredictable. So if you have like flow-limiting dissection, then you have to put a stent. So the patient was, very strict. I don't want stents. So I tried my best not to put the stents. But we agreed that in any case, we could at least treat the proximal lesion. I would avoid doing anything on the more distal one and putting a stent in the middle AD in a young patient. So put a stent in the more proximal lesion. About the recoil, this is something that we can face. So usually what I do, I bring this patient back in 3 months' time for a follow-up angio. So if we see that there's a restenosis, then we need to put a stent. We won't leave this lesion like that. And regarding the lipid won't go anywhere. So first of all, the lipid is spread. So that's the rationale when the LCBI marker is reduced after the angioplasty. If we put a stent, we're aiming to cover all these high lipid content plaques. That's the second thing. And the third one, regarding the drug-eluting balloon angioplasty, we have some preliminary data in the study from Netherlands that show that after drug-eluting balloon angioplasty, 6 months in a follow-up angiogram, we have some reduction in the lipid core of the treated plaque.
2 questions, please. One, why did you choose to apply high pressures with a semi-compliant cutting balloon at a ratio 1:1 as diameter? And the second, since you already knew you had some negative remodeling at the point of interest, why didn't you use paclitaxel instead of sirolimus?
That's a good point. To be honest, again, we don't have some data, that actually the paclitaxel is superior to sirolimus, perhaps in the Magic Touch technology that showed some inferiority. Indeed, you have a better drug release and absorption with the paclitaxel. But if you would argue that it's a 3 millimeter vessel, so it's not like a 2 millimeter or 1.5 millimeter, or you have severe negative remodeling. So that was the option. But you can use the paclitaxel. I don't have any objection on that.
The first question was extremely important, also because we got an hematoma. So why did you choose a 1.1 semi-compliant cutting balloon in this case, and not to get undersized, for instance? How much pressure did you use?
So essentially, it was not in 1:1. It was a 4 millimeter diameter vessel at that site, and I used a 3.5. So I went 0.5 millimeter.
Okay, you are using the EEL, and then you downsize.
Correct.
Half a size the cutting balloon.
Yeah.
Okay. Please.
So this is really interesting, and so when you spot, as our colleague said, negative remodeling, also some recoil at the proximal part, and you have hematoma as well. So the idea maybe to place a stent there, and maybe that would be more safer for our approach. And so if we work in a very busy environment, it's not easy to reschedule patients for a 3-month follow-up coronary angiogram. So is this how you deal with the other patients that you do drug-eluting balloons? You bring them back in 3 months to see if there is any more recoil, or this is something that you advise to do that in other
Most of the
well?
times that's what I do. Secondly, you will never achieve a like stent PCI result with drug-eluting balloon angioplasty. So you need to get used to that. Otherwise, if you don't feel, sure about that, or, safe, secure, whatever, just put a stent.
Who would put, just make a quick question, who would put the stent in this case? Just raise your hand. Who would put the stent? Who would not put a stent? Let's go from the other way.
Excuse me, Mr. Professor Toutouzas. I have, it's my opinion is that when we put a DEB or after the predilatation, we have to be sure that we have a stent-like result. I think that in this case, I will put a stent just in the beginning of the vessel, just in the stenosis, in the part that is a little bit dissected or we have the hematoma. Okay, for the other part of the vessel, I agree, we can put a DEB. And one question for you. After the discharge of the patient, how can we manage the antithrombotic treatment? It's about 1 month with aspirin and clopidogrel and then all the aspirin, or we have to put 3 months, or we have to make a new coronary angiography to be sure what we're gonna make next.
So I'm not sure whether there's a consensus about that. I usually put these patients in 3-month dual antiplatelet treatment therapy. And I mean, of course, I try before I discontinue the DAPT to bring them back and do the follow-up angiogram. But that's my personal approach.
The trigger here was that he was using imaging, and he was using hybrid imaging. Then we will have a session on the future, and so with the multiple information. So he was taking the decision about how to guide the procedure based upon imaging. But until now, there are very, very few data based upon imaging that can anticipate what is an optimal, what is a suboptimal, what is an acceptable, whether it's not acceptable result. So we are still very embarrassed to give you any answer to say that this is good, this is not. In presence of the hematoma, we needed to take into consideration that one significant part of the DCB-treated vessel, they are trying to have positive remodeling in the later follow-up. What does it mean? Is good? Is bad? Is based upon hematoma? We don't know. Once again, we needed to get more information about the value of imaging and physiology when we are using DCB, and not to stay alone with angiography.
Okay. I think we don't, Leonidas, don't have any more time. Grigoris is pushing you, so you're going to be the next case. So, well, thank you very much. Let's go.